All right.
All right, everybody. Welcome back this afternoon. It's 1 o'clock. We've got Dr. Smith, as you can see on your screens. It's a topic is toxicology. For everybody, we'll take a seat, sit down, and shut up. It'd be great.
If I don't want to.
Just kidding. I mean, you do whatever you want. It is your house. So,
It's okay.
all right, everybody. Dr. Smith, it is all yours.
Hello, everyone. I get the interesting topic of toxicology. I actually kind of fought for this one. It's a good one. Little background on me. I actually did EMS for 5 years during my college time frame, worked full time, enjoyed my time. I always have a soft spot for you guys, and there's a lot that you guys do that people don't recognize. So this is a really important topic to me, and this is a really important topic in general to you guys, because there's so much that you guys can do for a patient and make a big difference. So this kind of goes along with that. Everybody has the whole, just pick them up, load them up, and bring them to the hospital. Like, that's what they think that y'all do. But really, these particular presentations of patients can make a huge difference on a patient's life. If you notice something's going on or something's not right, you can be the first person to say, oh, I think it's this, or I think it's that, and it can lead us down a pathway, whereas it may take sometimes days to figure out what's going on with one of these patients. So it's a big deal. So, when we first start EMS stuff, everybody talks about OC and safety, your BSI, whatever. I would add to that, make sure that you're looking around the scene for clues about what's going on. A patient that you are suspicious that may have some sort of toxidrome all of the clues can be right there, and that can include smells. Things like cyanide can smell like almonds. There are all sorts of random things about the scene that we don't get to see that you guys get to be a part of and know. So, if the patient's surrounded by some sort of chemical, or if they're surrounded by pills, if there's drug paraphernalia at the scene, that sort of stuff is really important, and that's going to give you the information about what's going on with this that you may not, that we may not ever have picked up. So that's how important this is. And then just make sure that you're, gathering those meds if you suspect it's an overdose, making sure that you get the other important information, and just making sure you give that information to us that we can try to figure out what's going on. So all of this is going to get really complicated really quickly. And really, any of these, we're all going to do the same thing. Even in the emergency room, the majority of what we do for someone who has some sort of toxicology issue, we're going to take care of their ABCs, airway, breathing, circulation. If they're vomiting and they're not maintaining their airway, intubate them. If they're not breathing enough and they're hypoxic, give them oxygen. If they have an arrhythmia, there are some things we can do to correct that. If they have low blood sugar, correct the low blood sugar, and if they're seizing, give them Ativan, give them benzos, and fix the seizure. All of that stuff is the basic stuff that you're going to do for a toxicology thing. None of that's going to change in the emergency room versus in the field. So you might as well try to get some of this stuff done earlier, and then it will work out better for the patient. So we'll go into some more details about some of these sorts of things, but just remember the basic stuff. And as long as you're doing the basic things, this is basically how we handle any of these toxicology things to a degree. So we're just going to do a bunch of scenarios, and we're going to go through some things and try to talk about what I'm thinking about when I look at a patient that I am suspicious has some sort of toxidrome, and what's going on with that. So your first patient is a 22-year-old female. She's a known substance abuser. She's got a history of depression, borderline personality disorder, sometimes referred to as bipolar. She's known for all the substance abuse. She's surrounded by drug paraphernalia when you look at her on scene. She's got several empty bottles of medication surrounding her, and then you see a couple of pink pills on the floor. Her blood pressure is elevated, her heart rate's elevated, her temperature is elevated, Her blood glucose is within normal limits. Her pupils are dilated. She is flushed. She's dry. And you see a pink substance on her mouth. So what I'm usually thinking about is this kind of chart in my head. You know, what am I thinking about when someone comes in there? Because it's very easy to say, oh, she's a drug user, she's surrounded by drug paraphernalia, we've taken her several times for X overdose, what's going, you know, for methamphetamine, blah, 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 blah. And so the first thing I do is I kind of look at their physical exam, you know. So we know that she's got dilated pupils, her heart rate's up, her temperature's up. So those are kind of the two automatic things that I'm thinking about right there. But if you go back to what she was before, she's dry, she's flushed, and that would give you these sorts of things that we're looking at. So in that sense, she actually is an anticholinergic toxidrome and not a sympathomimetic toxidrome, meaning she's probably not just on methamphetamine. And this is how we figure this sort of stuff out. So a Benadryl overdose is the answer to what this was. She's covered in pink substance, she's got pink pills. You won't always necessarily have that, and I will tell you that a lot of these people are polysubstance, so this is obviously going to be a simplified version of how to look at this. But Benadryl overdose, they're going to be tachycardic, they're going to be sleepy, they're going to have hallucinations. It actually can prolong your QRS, so you do need to do an EKG. I will reiterate that several times. Do an EKG, do an EKG, do an EKG. You don't just do EKGs for chest pain. I did actually have someone tell me that once last year, because I asked them, did you do an EKG? And they were like, no, they didn't have chest pain. And I was like, oh God. Okay.
Oh, okay, yeah, sorry.
They can seize and they can go into a coma. So the treatment for most of this is just fixing any of the issues. If they're having a seizure, you're giving them fluids. You're probably, most of the time, if they really are a good Benadryl overdose, they're going to be not maintaining their airway, and they will probably end up on a ventilator and in the ICU for a while. So, I'm just going to go ahead and throw in the sympathomimetic. You're going to see, obviously, I think everybody has seen one of these this week. So, you know, one of the things to remember is, you know, you're going to have, the majority of our patients here are going to be methamphetamine, but I do actually see some patients who pop positive for coke on their tox screen, so there's some other things to remember about that. A lot of them are going to kind of have the same issue. They're going to be hyperthermic. They can have all sorts of complications from these. So they can have a widening of their QRS, which we'll go through some EKGs and stuff later. They can get MIs from this, so they can have a heart attack. Cocaine in particular can cause a coronary vasospasm, which can look like an MI, and actually cause EKG changes. And the only way to figure that out, that it's not an actual MI, is take them to the cath lab, so the cardiologist gets to deal with that one. They can have hyperthermic crisis, they can have seizures, strokes, they can go into heart failure, they can have renal failure, which I will remind you that renal failure can have really high potassium, which can cause a lot of arrhythmias and stuff, things to remember as well. And unfortunately, you probably have to think about, you know, if a child manages to get a hold of any of this sort of stuff, they're going to most likely present with tachycardia, agitation, and crying. So that's just something to think about. I haven't had one of those yet, but I'm sure that there's somebody in this group that has. So that's just our reminder of what that is. And they're going to be tachycardic. They're going to have an elevated blood pressure. They're going to have an elevated temperature, but they're going to be diaphoretic. They're going to be very moist. All right. Next thing. So we have a 48-year-old male. You get a call as a cardiac arrest. A bystander did CPR. You found the patient in the parking lot. They don't know anything about the history. You look at him and you realize he actually is breathing and he actually does have a pulse, but he's got a respiration rate of about 4. and he's not satting very well. This actually was a call of mine when I was in EMS. Before we even got the full set of vitals and that sort of stuff, just popped him Narcan, popped him right on up, and we're good to go. But if you were to do the full exam, you'd see that their pupils were pinpoint, their skin is dry. So this goes right back to this. And you do need to remember that you can have a cholinergic thing that can also present with pinpoint pupils. That's probably going to be more of your diaphoretic type picture, but this one was bradycardic, low temperature, pinpoint pupils, dry. That's your opioid type. So I'm sure everybody knows we're going to give Narcan for those sorts. The things you need to remember about some of these is there's some other medications. So a lot of times we think about, okay, this is probably heroin or oxy, but tramadol is also an opioid, and if someone overdoses on tramadol, they can have seizures. That's a pretty big one. We do have people here on methadone, and if they overdose on methadone, you can have a prolongation of your QT and go into torsades. So those are things to remember. The majority of these, depending on what they're on, will just get observed in the emergency department for a while. If they're on a major overdose, they'll end up with a Narcan drip. We had a overdose from the jail the other day that was fentanyl, actually several all at once. I'm sure some of you remember that. Things like fentanyl will actually not pop up on our tox screen for a positive opioid, so that's an interesting thing to know about. So if it's kind of strange, but fentanyl is kind of short acting, and so she was observed in the emergency department for a couple hours and then sent right on back to jail. So here's your torsades just for information. And what do we give for torsades? Magnesium. Perfect. Okay. So next patient is a 48-year-old female. She's got a history of depression, chronic pain, fibromyalgia. She's got a headache. She's vomiting. She's confused. She thinks she may have taken a couple extra of her medications. We've got a low blood pressure, an elevated heart rate. She's sat at 98 on Romaire. She's got a elevated temperature. Her blood glucose is fine. Her pupils are dilated and her skin is flushed and dry. So that's going to look kind of like your anticholinergic picture. That's your Benadryl type overdose, but you do an EKG. So in this EKG, you can see a widened QRS, and that should kind of tip you off to something that we may have already seen recently. You thinking about it? So you can have a TCA overdose that can present like this. That widened QRS can also be seen in a methamphetamine overdose. It can also be seen in a cocaine overdose. So what do you give for that? Sodium bicarb. Just make sure that this is a patient that doesn't have like a bundle branch block or something that is a known like baseline widened QRS. So you're not giving a bicarb for that. But you would think that TCA overdoses are not seen very often. We actually had one the other day for a amitriptyline, but one of the things that it's easy to forget is that we actually prescribe a fair amount of TCAs. I know when I was in the military and I was taking care of people, I prescribed Flexeril like it was candy, and there are still people who do that all the time, and we even do it out of the emergency room. So it's a pretty common drug that is a TCA. Amitriptyline is another known one. I see it more for people with chronic pain, or take it for like sleeping pills and that sort of stuff. So a lot of them are going to present with headache, vomiting, drowsiness. They could be delirious, or they could even go into a coma. They're going to have that same kind of anticholinergic that we talked about: dry, hot, dilated pupils, elevated blood pressure. They can have seizures. Remember to treat the seizure if they're having a seizure. And they can do all sorts of weird things to your QRS, QT, or PR intervals. They can actually go into BFib, BTAC, and you give sodium bicarb for that widened QRS. Okay. So our next patient is a 40-year-old male. He's got a history of, well, he's got no known medical problems. He is vomiting, he's got diarrhea, he's got abdominal pain. You don't know a ton about him. He's a farm laborer though. He's got a blood pressure that's normal. His heart rate is low, his respiration rate is up, his O2 sats are down. He's got audible wheezing in his lungs, he's got pinpoint pupils, and he's diaphoretic. So he's sweaty, he's got pinpoint pupils, he's got, so first thing you would do is ABCs, right? So you're gonna give him a breathing treatment, you're gonna take a look at him, and with a heart rate of 50, we're gonna do an EKG. And so this is one of those cholinergic type pictures. So, and just remember this sort of stuff. And there actually are placards you can get for like badges and stuff if you're really thinking about it. My only argument with this one is this particular one is that it says there's no change in heart rate, and the majority of them will have a decreased heart rate, so I just put that on there. So, you're going to see these for primarily your organophosphate poisonings. You can see it also for carbamates, which is an insecticide. You can see it with like Raid and that sort of stuff. It's randomly one of those bioterrorism things that they talk about. When I was in EMS, I worked in a big city in North Carolina, and so we carried pralidoxime or Tupam on our trucks in case we ever had one of those types of attacks. There was enough for me and my partner to have that. Of course, this was back in the day, so. But the big thing about them is they're going to have this kind of sludge appearance, which we'll talk about. They can have bronchospasm, meaning they, can have kind of wheezing. They can be basically paralyzed, or you can have like kind of these spasms. They can have seizures. And the big thing that you want to do for them is give them atropine. So atropine is your cholinergic that's going to help with that. So this is the sludge mnemonic that I use to remember all these sorts of things. So they're going to be salivating, they're going to be lacrimating, meaning they're producing breast milk potentially. They could be urinating on themselves, diarrhea, vomiting themselves, all of that. All right, so you have an unconscious 68-year-old male. He lives by himself. He's got no known medical problems. While you're looking around the scene, he's got a kerosene heater. He's got all the windows nailed down. There's no apparent ventilation. It's kind of an old, sketchy house. You look at him, and he's got a respiration that's up. He's got a heart rate that's kind of up a little bit. His pupils are normal, his skin is pale, he's extremely sleepy, he's not able to tell you a lot. He's accompanied by his daughter, and when you walk him to the cot, he kind of walks like he's drunk. Any ideas on that one?
Stroke.
Well, he's in the differential. He's diabetic, potentially, yeah. Any other thoughts?
Yeah.
Yep.
Carbon monoxide poisoning.
Carbon monoxide poisoning. I actually had this as an EMS call when I was in EMS. So it does happen. You'll see it for your kerosene heaters, anything that's fuel or wood burning. So that's stoves, that's gas heaters, that's, I don't know why anybody would be having a grill inside, but apparently that can be a thing. So the majority of these are going to present with just over 50% of people who have a carbon monoxide poisoning are going to have a headache. That's going to be their number one presenting symptom. And then followed by kind of GI nausea. They can have, kind of just generalized malaise, confusion. They can have tachycardia or tachypnea, meaning they're breathing fast or their heart rate's up. The classic thing that they teach about in textbooks with the cherry red lips or the red colored skin, most of the time if you see that patient is dead. So they're, that's it. It's really late at that point. So you need to have it high on your suspicion list. If you throw a pulse oximeter on one of these patients, they're going to have a normal oxygen level. And that's something to remember, unless you've got there are a couple of specialty pulse oximeters that can pick up on carbon monoxide, but the majority of them do not. And so you'll think, okay, they may have respiratory distress, but some of them don't. Some of them just have that headache. So it's something to remember of like, hey, they may not be complaining of shortness of breath, but it's something to have high on their list. It's something that I think about. It's very straightforward. If you've got you had a fireman in a fire who came out and passed out, okay, we probably are thinking carbon monoxide, but remember there are other things that can cause that. It actually can cause seizures. It can cause a heart attack, and if they're having a heart attack, that's a very bad prognosis. That means that oxygenation level is so low that they're not perfusing their heart well. The big treatment for them is high flow oxygen, and you can do that from the very beginning. If you are suspicious of it, put them on a non-rebreather. Nobody's going to fault you for that. In fact, they're going to think you think it's great. I had a patient the other day that had a suspected carbon monoxide poisoning, and I was waiting for the results to come back in the ER, and I put the patient on oxygen, and everybody was giving me a hard time about putting a patient on who was 100% on room air on high flow oxygen. This is why. And basically what happens is that carbon monoxide displaces the oxygen on your hemoglobin, and so the only way to get that better is lots and lots of oxygen to just kind of flood it off the hemoglobin. There are some cases where they have to treat them with a hyperbaric chamber. Okay, I'm going quicker than I expected to. Sorry, guys. So I have an 86-year-old female. She's got a history of dementia. She's got diabetes, high blood pressure, COPD. She lives with her demented husband. They both are pretty not with it when you're talking with them. And her blood pressure is 70/30. Her heart rate is 30. She's sat in a 98 on room air, temp's good, blood glucose is low, and she's confused and her pupils are normal. So, airway, breathing, circulation, right? So, make sure that we're, correcting that blood glucose. There's some fluids for that low blood pressure. We're doing an EKG on a heart rate of 30, and this is what you find. So that's a sinus, heart rate of 30 to 40 there, with a first degree AV block. What are we thinking? Too much blood pressure medicine. So that can be one of two blood pressure medicines. You can have beta blockers that can do this, and you can have calcium channel blockers. So if you have too much of them, they can have low blood pressure, they can have low heart rate, they can have confusion, they can get arrhythmias. The big thing is the change in glucose. So a beta blocker overdose is going to have a low blood sugar, and a calcium channel blocker overdose tends to have high blood sugar. So that's something that if you're feeling very Sherlock Holmes in your EMS time, you can be like, hey, I think they took too much of their blood pressure medicine, and I think it may be this one. They're taking both of these. They also can have seizures, and the big thing is give them atropine to get that heart rate up if you can, with that low blood pressure. With the low blood pressure and the low heart rate, with her poor perfusion, you may even be pacing them. And then I learned this last year that you guys don't carry glucagon on your truck, but we give them a ridiculous amount of glucagon for this. Pretty much the whole hospital's supply is basically what happens with this. So, all right. So you have a 76-year-old male. He's vomiting, he's got abdominal pain, he's got a history of heart disease, he's got a history of AFib, heart failure, diabetes, high blood pressure. This case is just to show you how complicated this can really be. So his heart rate's low, his pupils are normal, he's pale, he's clammy, he's confused. This is his EKG. Does anybody have any clue about that one? This is difficult.
Is it flutter?
So yeah, that's a flutter with a heart block at the same time. There's one particular notorious medication that does this for an overdose, and I throw it in here just because there are people who are still on this medication that we do see. I haven't had an overdose for one of these, but it is something to be aware of. Digoxin. Yep. And the other thing to know about this is this plant over here, which you'll see in a lot of people's yards, is digitalis. It's foxglove. If a kid eats that, it's going to be the same kind of thing. So something to think about. The majority of them are going to present with some sort of GI symptoms, vomiting, abdominal pain. They'll have weird vision changes. So some of them will say, yeah, I've got yellow vision. Some of them will say they can't see at all. Some of them will just have weird blurry vision. So there's lots of vision changes. They won't always complain of that, which is why this first scenario did not have that. They can have weird bradycardias. They can have weird arrhythmias. Confusion, and they can be altered. Just to give you an idea of what DIG can do. So the bottom one is kind of similar to what we had before with the flutter. You can have, this is some PVCs every other beat here. This is the big thing. This is a dysmorphic VTAC, meaning it goes back and forth for two different things. You can kind of see how it kind of alternates back and forth. They can go into full VTAC or VFib. So this is one of the classic things. If you ever see this on an EKG, it's rare. You're not going to probably see it, but if you do, you should be thinking DIG because it's pretty much pathognomonic of it. So, should have added a couple more scenarios. We can just talk about random stuff here. Obviously, there are a million things we can talk about. There are books on toxicology. There are 5,000 things that need to that we can go over. There are animals. There are plants. There are chemicals that all can cause issues. The big thing is to remember your ABCs. Making sure that you're correcting low blood pressure, making sure that you're checking an EKG. We'll go through some of this stuff. So sometimes we'll have things where a kid swallows bleach or something like that. The big thing to remember is not to have them vomit. Don't give them Ipecac. Things like activated charcoal won't help with some of that sort of stuff. Just knowing what's going on, bringing them in, a lot of that sort of stuff has to get solved by what we do is an EJD, which is a scope. So knowing that sort of stuff. We have snakes. We have 2 snakes in this area that you have to worry about. If they get bit by a snake, don't put a tourniquet on it. That makes that worse. Because when you pop off that tourniquet, all of that toxin goes up, and it concentrates the toxin in the limb that they got bit in, and so that can cause necrosis, that can cause compartment syndrome, that can be a big deal. There are a million poisonous plants. If you have any idea of what the plant is, take a picture of it, bring the plant. Don't bring the animal into the ER. We don't want it. I did see a good brown recluse bite the other day. If you see one of those, because you'll see a bunch of patients that say, "Oh, I got bit by a spider," and it's an abscess almost every time, probably from where they were using drugs or whatever. But if you actually do see a brown recluse bite, it has this appearance of a red, white, and blue. So the outer circle is kind of pink. Then there's kind of a white center, and then the very center of the circle is a blue, purple discoloration. So that's your classic brown recluse bite. There's nothing to do for you guys other than bring it in. We give them antibiotics. A lot of them will go home. The black widow spider can have all sorts of manifestations. A lot of those will be kind of, hey, I was cleaning out my garage. They like things like getting into spaces like that. I was gardening, I was doing those sorts of things and got bit. A lot of them will actually be fine, but the things to remember is, a lot of them will have, if they are toxic, they'll have this rigid abdomen, they'll get this paralysis that goes up. They may need to be intubated to control their airway depending on what it's looking like. So those are things to remember. And then if you've got
That doesn't sound fine to me. Just gonna say, that doesn't sound fine.
No. That's the bad side of the poisoning. Apparently, I was reading that there are some patients that just have minimal bite stuff, and I'd always thought, hey, it's always the classic abdominal rigidity, ascending paralysis, and they're done. Was my original thought, but a lot of them will get localized bites that don't need anything, or they'll get kind of just like spasms in that leg or whatever, and they won't get anything else, which is something new that I learned while I was researching all this stuff. And then just remember from your hazmat stuff, if it is a hazardous material that they're exposed to, we need to know what the placard is. That way we can look up all this stuff. I have no way of knowing what's going on. If we can't look through all that sort of stuff, we'll have to call poison control. There's some hazardous material resources, which you guys probably know way more about than I do. I don't know if you had to do, I had to do like a hazmat course thing when I was in EMS.
A lot of ours have been through hazmat.
Yeah.
We have the ERG books in every ambulance.
Mm-hmm.
We have an unknown amount of chemicals that run through
Exactly.
the interstate. I-44 is probably one of the busiest interstates in the nation, so I would assume that most of us have a pretty good vast majority of information on that.
Yeah.
We've talked about it in the past. So.
Yeah, so the big thing is just making sure that you're paying attention to what's on the placard, making sure that you're relaying that information, talking to some expert who knows out of that what to do, and paying attention to your hot, warm, cold zones, that sort of stuff if you're in the field and you have some sort of explosion. When I was in EMS, we had a explosion of a sausage power plant that basically became this giant mass casualty thing, and there was leaking of what we found out was ammonia later, but there was this smell in the air, and there was all this what's on these patients, what's going on with this, and so learning which zone to be in, what PPE you have to wear for each part of that, paying attention to all of that sort of stuff, and relaying that information for us, and letting us know, because there's some people that have to basically be deconned before they can even come in the ER. So, and then there's obviously food things that are toxins as well. So that's your pufferfish. Not that we have a ton of that around here, but yes, yeah. There is a thing called scromboid and ciguatera. Both of those are things that you can have after eating seafood. And we do have some seafood restaurants around here and people who eat seafood, but so you can actually have reactions to that. Most of those are kind of an allergic reaction type piece where you give them Benadryl. but it ends up being like a flushing reaction. They have vomiting, they feel really terrible, and the majority of those are histamine reaction to that, but there are ciguatera toxins in things like, I'm trying to think which fish. There's a handful of fish that are, we don't have as much around here because we don't have that, but things like mahi and stuff like that, yeah, that you can actually have reactions to. So,
Good fish.
big thing is remember to do your ABCs. Always take care of all that sort of stuff because the majorities of these people are just going to get fluids. They're just going to be monitored. They're just going to have their airway taken care of. They're just, that's really the gist of all this sort of stuff. Any questions for me?
We're about 20-ish, 30 seconds behind, so it may take us a little bit to come up with questions. But
Mm-hmm.
With the carbon monoxide and stuff,
Mhm.
poisoning, how long do you like blast them with like the, 100% oxygen before you like, I guess,
Yeah,
just
so in
our sense, like,
Yeah, in
How
the
long?
emergency department, they'll get blasted with oxygen for a long period of time. We'll actually track down their carbon monoxide levels. So they have to, depending on how high the carbon monoxide level is, we may watch it go to half, or we may watch it further down depending on how toxic the level is.
and is that level, I guess what I'm asking is it right then and there, like are you gonna trend up if you don't?
If you've got them out of the source, you shouldn't. If you've gotten them away from the carbon monoxide, it shouldn't trend up. It should be, your highest level should be whatever their blood level is when they get to the emergency department, and you give them oxygen and they trend down. The thing to remember is that not everybody knows they're having a carbon monoxide poisoning. There have been stories about people who are getting carbon monoxide poisoning from their cars, and they're like driving around and they're not knowing why they're getting these headaches. And then it can be, if you're not getting exposed to the high level of oxygen to get it down, it can kind of build up chronically. So some of these people can have, it won't be quite as acute as this old guy that when I presented. So it has to be kind of a high index of suspicion. And like I said, that it can be subtle, and it may be things that we find days down the road if we don't know, which is why it's so important. If your spidey senses go up when you're on a scene and it says something's not right here, that means a lot, and that can really help us figure out what's going on with the patient.
So to
Santa
add to
will tell you
that,
a bunch.
can I add to that?
Yeah.
No, you cannot.
We have,
The-
yeah, go ahead.
I'm just kidding, go ahead.
We have in our bat chief a pulse oximeter
Mhm.
that will read that carbon monoxide. The question is most of us, even myself, I know how to turn it on and how to place it on the finger, but I don't know what I'm looking for.
Mm-hmm.
It's gonna read a number, but what am I looking at for a number? Would you be able to answer that?
There's a gauge, yeah.
Yeah, there should be a gauge,
Smokers
or
walk
I'm
around
not
with
sure about
34.
that sensor on like what the high level would be for that. I would imagine there's some sort of thing that says this is elevated, because I don't think it's going to be the same as like what our lab
Like a
would
lab.
draw.
Yeah.
Does it read a
The
number on
red
the left side of it?
57s, over 15 is usually an issue.
Okay,
I'll get you a chart,
that'd be great.
yeah. I
Because
know,
that would
I
be
know what you're
some-
talking
There you
about, so
go.
that
Do we have anything
rainbow
like that that you
PET CO2 technology,
Never-
or CO technology, I mean.
Mhm.
So basically, we just
There's
have
a-
to wait for
there's a
the
chart.
lab
We
unless
have
it's
to
like
wait for the lab
suspected.
and be suspicious. Yeah,
Yeah.
it's weird.
Smokers
Have you
walk
treated
around
any
with
people
probably
like
3
that?
or 4 all the time.
Painful.
Interesting.
I haven't really seen anybody, but I guess
Yeah, it's
maybe
it's
not
not,
anyone either.
I've had 3 cases in the last year, I guess. And I think that's more than a lot of people. I get random stuff.
Yeah.
So, yeah, all of them were very straightforward for me. One of them was a firefighter, one of them was a guy who had been working in, I think, a Walmart back room where one of the carbon monoxide sensors had gone off, and he had ignored it and spent 30 or 40 minutes continuing to work, went home and had this like awful headache and decided to get on Google and read about it, and then came into the ER like 12 hours later and had a pretty high elevated level. So I'm very curious to see what his level was right after it. It will trend down a little bit, but it trends down better when you have the oxygen to displace that carbon monoxide.
Right.
So on the one that you guys said that you usually give like oral glucose because their glucose goes down is like D10 or D50. Something that we could give in a truck. I can't remember which one it was. It's like one of the last ones where it dropped the blood glucose as well.
Oh, I don't care about
But
oral
you guys
versus
use,
IV.
like,
Oh, you're talking about beta blocker, right?
Yeah.
Probably beta blockers. I don't care oral versus IV. If they can take oral intake, then it's better to do oral, but it takes a pain. It's a pain in the ass to wait for oral glucose to get your
Right, but
glucose
we can
levels
use
up.
like D10
Yeah,
and D50 as
yeah,
well.
absolutely.
Like I didn't know if it was like an oral glucose.
No. Glucose of some sort. Get the sugar up. Yep.
Right
On
on.
call.
Yeah.
Alright. Safe.
Thank you.
I see a ton of thank yous online
Okay.
and
Ton.
no questions,
Okay.
so.
Hopefully that was enough time for you guys.
No,
I know
it's
that's like
perfect.
a
Oh, that's
40
perfect.